This is Kelsey Kennedy, and in this week's OCT Feature of the Week, we are presenting our work in evaluating the diagnostic accuracy of quantitative micro-elastography for margin assessment in breast-conserving surgery. This work was carried out at the University of Western Australia and the Harry Perkins Institute of Medical Research. It was funded in part by OncoRes Medical, in which I disclose financial interest. The goal of this work is to improve outcomes in breast-conserving surgery for treatment of breast cancer. In breast-conserving surgery, the goal is to completely remove the tumor along with the surrounding margin of healthy tissue. In cases where a tumor is found at or near the boundary of the excised tissue following surgery, the woman might have to be called back for a second surgery, a re-excision. And unfortunately, this happens in 20 to 30% of breast-conserving surgeries, which make up the bulk of all breast cancer surgery. This is an enormous cost to the healthcare system economically, as well as physical and psychological burdens on the patient. So right now in breast-conserving surgery, the intraoperative margin assessment tools used during the surgery include frozen section histology, as well as X-ray and ultrasound. But these all have limitations, including being time-consuming or too low resolution or low accuracy, especially for what's known as ductal carcinoma in situ, or DCIS. OCT has also been proposed for intraoperative margin assessment in breast-conserving surgery due to its high speed, high resolution, ability to do 3D imaging, as well as its ability to be translated into compact probes for potential in vivo imaging. Some initial promising results have been demonstrated. However, a lot of these studies were carried out in dissected mastectomy specimens, which are specimens taken from procedures where the whole breast is removed and then dissected to expose a bulk of either tumor or healthy tissue. In contrast, in breast-conserving surgery, the intact specimen that's removed and the margins that must be assessed will often contain what's lower grade tumor or less progressed tumor than you generally find in mastectomies, and the geometry of the specimens is very different. The largest study carried out to date in intact breast-conserving surgery specimens resulted in much lower accuracy reported so far. And the big question mark that remains is whether OCT alone has the contrast to tell the difference between healthy, benign stromal tissues in the breast and cancer tissues in the breast. So to improve this contrast, our group started to investigate whether the elasticity of the tissue could be probed using a technique known as quantitative micro-elastography. In fact, the surgeon today uses their sense of touch to guide where to cut during breast-conserving surgery. We know that cancer changes the mechanical properties of the tissue from the early onset of cancer all the way through its progression. So the idea for quantitative microelastography is to translate the surgeon's sense of touch into an image that's quantitative and that is visualized at a microscopic scale, a scale below that can be sensed by human touch. Quantitative microelastography works by using OCT to measure the deformation of the underlying tissue after applying a compressive load. This deformation or strain in the tissue is only part of the equation to get to quantitative elasticity. Therefore, we use a calibrated layer of silicone whose stress-strain properties are known to measure the local stress at the surface of the tissue and enable a calculation of quantitative elasticity throughout the tissue. We've applied quantitative microelastography in mastectomy specimens previously and shown promising initial results, highlighting the additional contrast that probing the elasticity gives on top of the OCT alone. In fact, combining the two, we can overlay elasticity on the OCT, knowing that OCT actually does give very good contrast of what's known as adipose tissue or fat tissue in the breast. And then the elasticity gives more nuance within the non-adipose tissues of the breast, highlighting the stiffer regions that correspond to tumor when we compare them to postoperative histology. To translate this technique closer to clinical development, We carried out a study to determine the sensitivity and specificity with which OCT and quantitative micro-elastography could detect tumor within 1 millimeter of the boundary of excised, intact breast-conserving surgery specimens. We recruited 90 patients for this study, and we also had 7 readers that performed a reader study to determine the diagnostic accuracy. We used postoperative histology as the ground truth, and we also used 19 of the 90 patients' data sets as a training set to train the readers. Images for this study were acquired on a wide field OCT and elastography system that we've deployed in our previous studies. And from these wide field images that were 46 by 46 millimeters on the en-face plane, we selected 10 by 10 by 1 millimeter regions of interest to use in the reader study. The selection criteria for the regions of interest including having confident histology correspondence, as well as uniform contact between the compressive probe and the tissue. The images were presented in the en-face plane, and the readers could scroll through in 3 dimensions to look at each en-face plane in depth every 10 microns. The elasticity was overlaid on the OCT in regions of non-adipose tissue. The adipose tissue was segmented out and presented with OCT only, given OCT's good contrast in adipose tissue, and the challenges in overlaying elasticity on these regions due to the inherent lower signal that is collected in regions of adipose tissue. Images were co-registered with postoperative histology using photographs taken during the image acquisition compared to the cut-up diagram that was provided by pathology. In this institution, histological sections were performed in a plane orthogonal to the en-face plane in which images were viewed. Thus, careful co-registration of the images with the sections in which histology was performed was key to ensuring accurate ground truth in the tissue types present within each of these planes of the image. After all image acquisition was complete, 71 specimens were included in the reader study, while 19 went to train the readers. Out of the 71 included in the reader study, 154 regions of interest were ultimately included. Out of these regions of interest, 24 had what we would call involvement. That is, cancer was present within 1 millimeter of the boundary of the excised tissue. This corresponded to an overall prevalence of about 15.6% in this patient population. This is similar to the overall prevalence of close margins following breast-conserving surgery more broadly. Readers were trained to detect cancer in OCT and QME images using the following criteria. In OCT images, some of the main criteria included looking for areas of solid tissue, that is non-adipose tissue, and also assessing whether that solid tissue had continuity with depth. We found that benign connective tissues in the breast tended to be less continuous. That is, they might look like a small strand that's not connected to a larger mass, whereas tumor tissues tended to be connected to a larger mass beneath the surface of the tissue. So as you scrolled in depth, you would actually find a continuity of that solid mass. In QME images, the main criteria was assessing whether areas of high elasticity were present using a quantitative scale. The next 3 slides show some key results from this study. This first set of images show benign tissues in the breast. That is, they do not contain any cancer, so are called negative margins. In each case, we've highlighted with the red dashed line the plane in which the histological section was performed for these images. On the left-hand side, we see an example of predominant adipose, which OCT highlights nicely with the honeycomb structure in the left-hand image. There are also some small strands of connective tissue that are highlighted as being low elasticity or blue in the elasticity overlay on the right. This corresponds well to the predominant adipose seen in the histology below. The right-hand set of images shows a combination of benign stroma or connective tissue along with a portion of adipose tissue in the bottom right of these images. This also corresponds to the combination of stroma and adipose that's seen in the corresponding histology. In contrast, these images show examples of positive margins, or tumor that came all the way up to the boundary of the excised tissue. In both cases, we are looking at invasive ductal carcinoma, that is, carcinoma that has escaped the breast ducts and is invading the local tissue. In both cases, the invasive ductal carcinoma is characterized by high elasticity and corresponds to the dense tumor cells seen as the more purple nuclei in the corresponding histology below. Finally, two other types of malignant tissues were found in this study. The left-hand side shows an example of a mucinous carcinoma. This is a type of cancer in which the tumor cells produce a liquid mucin substance. Here again, the elasticity actually was found to be elevated, and we believe this could be due to high interstitial pressure due to the fluid that's present in these tumors. The mucinous carcinoma and the corresponding histology can be seen on the right-hand side of the histology, where the groups of tumor cells in purple have produced a liquid mucin that surrounds them. In the OCT alone, this liquid mucin actually looks similar to adipose, and the elasticity image provides much clearer contrast between what is tumor and what is benign. Finally, we have an example of ductal carcinoma in situ. That is, tumor that is still within the duct and has not yet invaded the surrounding tissue. Here as well, the elasticity creates contrast between the area of DCIS, which is shown in the bottom center portion of the image, compared to the OCT, where surrounding dense but benign stroma is very difficult to distinguish from the area of DCIS. The table below shows the results of the blinded reader study. 7 readers participated, including 5 clinicians and 2 engineers. The results show a superior accuracy when using quantitative micro-elastography compared to OCT alone. The results using OCT, sensitivity of 69% and specificity of 79%, correspond well to other studies that have been carried out previously looking at OCT for use of margin assessment in breast-conserving surgery specimens. However, when we add the elasticity criteria in quantitative microelastography, combining the two images resulted in an 80% sensitivity and 99% specificity. Finally, using only the elasticity criterion alone resulted in about 93% sensitivity and 96% specificity. The higher sensitivity in using quantitative microelastography alone compared to combining it with OCT could be due to ambiguity existing in the qualitative nature of the interpretation of the OCT image compared to a quantitative nature of interpretation in the elasticity image. In conclusion, the motivation of this work is to improve outcomes in breast-conserving surgery and reducing the number of repeat surgeries that are needed. The 71 patient reader study that was carried out here resulted in excellent diagnostic accuracy for quantitative microelastography with sensitivity of 93% and specificity of 96%. Ongoing development is translating this work into a handheld version so that the surgeon may actually scan the tissue in the surgical cavity during the operation and not necessarily rely on the benchtop setup that was used to carry out the present study.